Recording.
Fab,
Thank you.
So pnawn da, croeso I sesiwn cuno a dysgu a gynhaliau gan raglen gwasanaethau ansoddiadau Rywol Cymru. So welcome everybody and good afternoon. I'm Jo Williams, I'm the Programme Director for the Welsh Sexual Assault Services Programme, and today we're hosting a session on updated post-exposure prophylaxis guidance for children who've experienced sexual assault. And the session today is going to be taken by Catherine Simpson and Jennifer Evans. So I will pass you over to them now. Thank you.
Hi, pnawn da. If this is a session that we've prepared with myself and Dr. Jennifer Evans, and it's really just to give an overview of use of post-exposure prophylaxis in children. It's specifically written around the after use following a sexual assault, but obviously it has its uses with other potential exposures. So Andy, if you can maybe move on to the next slide, please. So back one. There was some updated guidance that came out from CHIVA on post-exposure prophylaxis, which was updated in November 2021. And so this sort of guidance is based on those recommendations. And what we've attempted to do is to make it as simple as possible, and also to cover the age range and cover all the different circumstances with respect to being able to take a tablet or needing liquid formulations, etc. And there has been some guidance that we've developed in NSF Cardiff, and we're happy for that to be shared wider and adapted for local use if that's something that's of use. So that's something we can share. Next slide, please. So what we're hoping to give you as learning outcomes from today is an overview of the risks of contracting HIV, an overview of what is PEP and how it works and how effective it is, and then talk a little through how we risk assess exposure, talk through what medications we use and some of their side effects, what monitoring is required and what follow-up is required. So I think this was moving on to the double act. So if I hand over to Jennifer, please.
Thank you, Catherine. So hello, everybody. My name is Jennifer Evans. I'm a paediatrician with a specialist interest in infectious disease and immunology. Sorry, I'm just giving a lecture. Yeah. Sorry, apologies. So I think the headline is that the risks of acquiring HIV in the community are extremely low, so that's a very important sort of message. There's a huge amount of anxiety around HIV, understandably, but the risks are very low. And for example, just moving away from this sort of arena, there's no indication of any horizontal transmission from child to child or in school classes and things like that. So compared particularly with hepatitis B, it is is much less infectious virus. The other thing that's happened in recent years is that people, when they have a diagnosis of HIV, are now treated from early on in the disease with combination antiretroviral therapy, which with the aim of suppressing their viral load down to a level of being undetectable. And once you're undetectable, then you cannot transmit the infection to a sexual partner. So you become non-infectious, and there's within the HIV community, there's a sort of saying, U equals U, undetectable equals untransmissible. There was a situation a few years ago, and those of you who've been around for a while will know that there was the time where people would only go on to treatment once their disease had reached a certain sort of stage of advancement, and but that isn't the case anymore. So now once you're you're diagnosed and you're going to a clinic, you're put onto treatment, and that treatment is very successful. Of course, there will always be exceptions to the rule, and people who aren't taking the treatment, or people who don't want to, and things like that. But it actually means that the number of people who can potentially transmit their disease has become lower and lower in recent years. And once you're on treatment, then a very high proportion of people, you see 99% of people in 2021 who were known to have HIV were accessing antiretroviral therapy, and 98% of those had achieved virus suppression, rendering them uninfectious. So the next slide, please. So children do remain, sadly, at risk from acquiring sexually transmitted diseases, both through consensual sex, even at a young age, and as a result of child sexual abuse. So that's the sort of area that we have to think about. The risk from biting or from picking up a needle is extremely low. And really, needle stick injuries just from picking up needles in the park and things like that, we don't use prophylaxis. It would only be if somebody had a needle stick from a fresh needle. So, for example, in a hospital situation, or in a situation where drug use was occurring and there was contact with a fresh needle. HIV infected fluids can't get through intact skin. But sadly, sexual abuse is a particular risk to children because of multiple exposures and trauma, and the susceptibility of the genital area too, because it's just not as protected as older people. So it's a very small group, but a very challenging and a very sad group that we're really talking about. Just going back, we do have a few adolescents in Wales or in the UK. Oh, the slides have gone. I don't know if that's me. Who have HIV, and they've been known to have HIV since they were born, and so we did used to sort of charter the waters of them becoming sexually active, and we do a lot of work with these children about informing people, informing potential partners and things. But all of the children that we manage in Wales are on treatment and have an undetectable viral load. So I'm not saying that, in no way do we say that gives them free license to sort of go out there, but we're not having sort of accidental exposures with sort of broken condoms and resulting in needing post-exposure prophylaxis, so that if there is an incident where a child with HIV who has unprotected sex, if they've got an undetectable viral load, there's no need for their partner to have post-exposure prophylaxis. Okay, the next slide, please. Oh, are the slides okay? Are they not moving?
I think Andy's connection has crashed, so I've just asked her to send them through to me, but I'm not sure if there's another copy of them.
I've got them. I'll put them up now.
Thank you.
Right,
you see
so
that?
well, I could, but it just went.
If we can message Andy to say I'll manage the slides, because I think as she keeps coming in and out, it's disappearing.
Yeah,
Okay.
no problems, I will do.
Okay, so so these are risks. These have come. Well, these figures have come from studies to try and calculate what the risk is. So and as you can see, they've calculated the risk if you get a needle stick from somebody who it'll be a newly diagnosed patient, somebody who's not on suppressive antiretroviral therapy, 1 in 333. Anal sex is much more risky than vaginal sex, and a human bite is of extremely low risk. One of the reasons for sort of trying to estimate these figures is it enables you to somehow put a risk on a patient that you're seeing. So the next slide, please. And there is a way of calculating the risk. So risk of transmission, risk of source is HIV positive with a detectable HIV viral load multiplied by the risk of exposure. So if it depends who is the perpetrator or the person from whom you've maybe had a needle stick in a hospital situation. That's much easier to sort out. If you've actually got somebody who's being sexually abused, it becomes quite difficult. But you might know something about the environment from which that person is coming. If somebody who is perpetrating a sexual abuse, I always tend to err on the side of sort of caution, and that this person is indulging in at-risk behaviour, so therefore they're increasing their risk. But as you see, this is a calculation for contracting HIV from a needle stick. Comes down to an extremely low level. But if you do get a needle stick from a patient who's considered to be at significant risk of having uncontrolled HIV, then post-exposure prophylaxis is recommended. But as I say, a community needle stick would not be wouldn't be recommended. The next slide, please. So what is post-exposure prophylaxis? It's a short course of anti-HIV therapy, the same anti-HIV therapy that patients are treated with, taken as soon as possible after HIV, to try and wipe up the virus before it sort of infects a significant number of cells and takes a hold. So it's been demonstrated to work. It's the premise behind the prevention of one of the premises behind the prevention of mother to child transmission. But the absolutely key thing is it needs to be started early. It won't work started sort of late, once the virus is incorporated into the white blood cells. But in a patient who's seen ideally within 24 hours, but up to 72 hours after an exposure, it's definitely worth doing. And obviously, again, sadly, with child sexual abuse, where there may be multiple episodes of abuse, then sadly, you may miss the boat because that's where your history becomes important. But if it's this is the first episode, it's worth definitely trying to prevent infection. And it's not, as opposed to the pre-exposure prophylaxis that you hear talked about, which is now becoming increasingly widely used amongst at-risk populations. It's not a means of control. It's an emergency treatment, and it's not something. It's not like the morning after pill or something like that. Okay, so the next slide, please. So it needs to be started as early as possible to wipe up whatever virus is around, and it needs to be continued for 28 days if tolerated. And often if tolerated is quite a key thing. The medicines are actually much better tolerated than they were. When I gave this lecture about 5 years ago, the medicines that we were offering were completely horrible, and to get somebody, particularly a small child, to take that for 28 days was a real challenge. But they are much more palatable now and much easier to take. So things are going in the right direction for many reasons. Next slide, please. So it's a combination therapy, and that is the essence of anti-HIV therapy. They are 3 drugs is the cornerstone of management, working in slightly different ways, and many of these drugs are now for adults combined in a single tablet. EastEnders is covering HIV at the moment, and I was a little bit concerned because the chap with the HIV just seemed to be taking only 1 drug when they showed his bottle of medicine. So hopefully they'll correct that. But yeah, so it's 3 drugs, and the choice of a drug means they're drugs that are particularly good at bringing viral load down quickly, and they're also very good at getting into the right places. So if we move on to the next slide. And I think I go back to Catherine now.
Yeah.
So Catherine's going to talk about the sort of paperwork, and then we'll come back and talk about the drugs.
Yeah, so this is just some sort of screen clips from the paperwork that we've developed, and and essentially you know, anybody who's seeing a child where they need to consider this, it's just a case of what the details that would be useful to record. So the main things is trying to work out the date and time of the potential HIV exposure, and then working out your time since the HIV exposure. You know, in clear disclosure cases, that's a fairly easy thing to do. If you've got a young person where maybe they're a younger child, and they aren't able to give a clear picture of when something may have happened, sometimes it can be looking at when was the most recent likely exposure to the person at risk. In the same ways we do when we're trying to assess whether we're seeing a young person or a young child within a forensic window. So sometimes it is clear, sometimes it's a best guess, and depending on the risk of the concerning incident, you know, you make a best decision on the best information that you can, but it's not always as exact as we would like it to be. So the details of the source, I've got to say the majority of the time that I fill in this paperwork, I'm crossing that out because we don't know. But there might potentially be a time where you are aware of whether the person, the details of the source may be HIV positive, and whether they may be on treatment or not, and whether they've had a recent test to show their viral load. With respect to the details of the source, we then look at whether they are potentially in a high risk category. And so the high risk categories are men who have been having sex with other men, whether they were born or living or have lived in a high prevalence area, and that is information that link at the bottom in blue can take you to. Whether it's a person that we know who is a commercial sex worker, or if it's somebody who's an injecting drug user from London, Glasgow, or other high-risk countries. And then I'm not sure how well this is projecting, but we then look at sort of this risk table with respect to the risk of the source and the risk of the presumed assault. And again, that's sometimes a case of educated guesswork with younger children with respect to, you know, do they have injuries present, or you know, as well as what they may have been able to tell us. So putting those together and following it through, and then it either falls into a yes or a no, generally not recommended, and a consider. This table over time has changed with far fewer definitely yeses, and sort of a downgrade from consider to generally not recommended in some of the boxes. And then obviously, if we're looking at giving post-exposure prophylaxis, we need to be noting any past medical history, specifically where there's any severe renal disease, any other medications that the child or young person may be on, and obviously any allergies. And then we move on to the sort of looking to see which is the right drug formulation for that young person, depending on their age and their weight. So we're not calculating bodily surface areas, which I think it used to cause people stress in the past. So again, I'm not sure how well that's projecting, but so we have sort of the table there that covers the ages, so over 40 kilograms and over 12 years. It's basically the adult starter pack, which is what we have in our fridge at home. I suspect is fairly widely available across Wales. And it's just to note that you know, there are alternatives depending on if a person is pregnant. Ideally, they should be having a slightly lower dose of the raltegravir, although the guidance does say that if that's all you can get hold of at that time, then it's better to give the PEP rather than wait and miss that window, and then obviously try and get the better lower dose as soon as you're able to. And then the table goes on to show greater than 6 years and the weight between 25 to 40. And then the younger child again with formulations that are liquid preparations. So we can share these slides afterwards. I think it's probably the best thing to do, so I suspect you'll be able to see it a little clearer than on the slide here.
I think I was coming back in on these slides actually,
yeah.
Catherine. Sorry, yeah. Can you just go back to that slide, please?
Yep.
So I just want to say thank you to Fiona Clark at this point. Fiona Clark works in pharmacy. A lot of you will know her, based in CRI and UHW, and what she doesn't know about HIV medication is not worth knowing. And I think if you look at the guidance that came out of the Children's HIV Association, we've actually, even though you might look at this and think, gosh, this looks complicated. Well, if we just chucked the Chiva guidance at you, I think you'd have gone bananas, because we did. I think as HIV treatment has advanced, there's a lot more choice, both in types of drug and also in formulations. But then, of course, that can then make life really confusing. And the other thing that we want to have is to have immediate drug availability. So to have drugs available in the SARC so that people can access them. This is never going to be a Wednesday lunchtime. This is going to be, this is at night, this is at the weekend. So we wanted to make sure that the drugs were available, and they could be dispensed immediately. I think when you start looking at this, and I think it is really worthwhile, as I say, Catherine will we'll make these slides available, and I think I'm right in saying that in the SARC, that the guideline is available. So you sort of look at it and you think, oh gosh, is that a mistake? There's 600 milligrams of raltegravir here, and then in the alternative it's 400 milligrams. That's because these are different formulations, so the bioavailability of the different formulations changes. So you sort of have to trust the fact that there are sort of different doses for different things, and just trust us that we sat there with Fiona, who knows what she's talking about. So these doses are right. It just looks a bit weird, and that's the importance of actually sharing this information. So if you're over 40 kilograms, you're actually classified as an adult, so you can have, that is what the adults would have. And the alternative there is because adults who sadly some of these youngsters refuse to take tablets, so we had to then say which ones can be crushed and give us reliable bioavailability, hence the alternative. So and then a dose there if you're over 6 but not yet reached 40 kilograms, or if you're less than 25 kilograms, is a slightly different sort of combination. So if we go on to the next slide. Gosh, it's getting smaller and smaller. And basically this is just sort of there's a formulation panel there, because raltegravir can be given as a chewable tablet, as well as there's tablets that you can swallow, which are the 600 milligrams ones. There's tablets that you can crush, which are the 400 milligrams, or there's chewable tablets. Now, I haven't actually tried these, but I think they are reasonably palatable. So, and the doses obviously for the chewable tablet are very different than the other doses, but they're all written there, and you should be able to find your person. These are all available in the SARC. Dolutegravir, can you just go back? Sorry. Dolutegravir is again, there are tablets that can be crushed, but there are tablets that then can be dispersed. And again, a very weight specific dose that you should be able to find your person on there. And the next one, please. So the very small children have to rely on what are 2 of the older HIV drugs, and which are available in liquid form. And these have to be taken twice daily. Well, definitely AZT has to be taken twice daily, and 3TC also twice daily. but there's an option there that you can take it once daily. So it depends on the volume and whether you think you're going to be able to get it into somebody. The downside of this is, you know, as children get sort of bigger, the volumes become completely unpalatable. So that's why we work very hard to find drugs that we could either crush, chew, or disperse for the bigger people. But babies and we use AZT in babies still fairly regularly in their post-exposure prophylaxis, and so it is that is tolerated. Okay. If people are on drugs already, so if people are on medication for other reasons, then there's a useful website where you can actually put in what drugs they're on to see whether they interact, and with advice on what to do with if they're already taking something. So that's that website there. And the side effects, the common side effects, are sort of listed on those previous two slides. Most of them are sort of nausea, vomiting, abdominal pain, occasionally rashes and things. The drug that we used to use, called Kaletra, which has fortunately disappeared from this guideline entirely, really made people feel sick to the point that you actually needed antiemetics, and then that just completely increases your medication load and tablet load, and it was a bit of a disaster. So I'm very, very glad that we've got rid of that one. And also in young people, very few of them, a lot of them tend not to be on medication. So that's quite useful, whereas I think in the adult world, this does become a very significant problem. The next one, please. So we do need to take bloods, baseline bloods, to see whether children are already infected. And of course, this becomes very important when you think somebody may have been serially abused. Because they may have got into trouble already, and we need to know that, and that will inform our decision making later on. It shouldn't delay taking their post-exposure prophylaxis. It won't cause any trouble, but as long as we get those bloods in the first 72 hours, you'll still be able to interpret whether that, you won't have a full antibody response. If you've got a full antibody response within 72 hours, it means you were infected before. So it shouldn't delay starting it, but you also need to know what the full blood count UNE and LFTs are, but nothing should delay taking those first doses. We can sort out the bloods later. Okay, next one, please. So they need to then be reviewed within 72 hours of starting that medication. It's not the only reason for being reviewed. Obviously picking these people up is really very important, and it will depend very much on the age of the child, the social situation of the child. I think the last case we had, it was completely obvious it was appropriate to be seen in the sexual health clinic in CRI, but obviously linking in with somebody like Catherine or myself, because the child is under 16, being seen in an adult scenario, that they still need to have some sort of pediatric input. But if they're going to need sort of much more sexual health sort of type input, then that might be the right place for them. Whereas a much younger child or a much more immature child, it'd be more appropriate to come to pediatrics. We do run an HIV service. Unfortunately, we're not a very infectious diseases is not yet formally funded in Wales, which is a situation that we're going to hope to see changing. But myself and the clinical nurse specialist, Jess Pitcher, who's on this call, would be available. And the phone number is there or available through switchboard. But in an emergency, St Mary's Hospital in London have a 24/7 pediatric infectious disease service. So if there are concerns about specific test results or what drugs to use or drug interactions, there would always be somebody there to discuss a situation. And the other situation that I've been called about is, do I treat or not? This is the situation, this is the history I've got, and it's often quite good to brainstorm as to whether you should treat. But my rule of thumb is, if you're concerned, you can start it and then it can be stopped. It's better to do it that way than to sort of think 2 days later, actually, perhaps I should have done. So, but I'm always happy to be called about. I'm not really quite sure what to do here, and to just thrash it out between us. And I think Sian Moynihan's on this call, and I think, you know, we've had that conversation in the past, and just to try to decide what to do for the best. Okay, the next slide, please. So we would try, as again, either in the sexual health clinic or in the pediatric infectious diseases clinic, we would try to follow up and see how they're getting on. Probably call them by phone between 0 and 14 days, and link in with, because they can't have the STI swabs and pregnancy test in the pediatric clinic here, so that would be a reason for linking in with the CRI sexual health clinic. But making sure also that hepatitis B, which they will have had the first shot of that in the SARC, and then making sure that the GP gives them at 1 month and 2 months, and then doing the follow-up bloods to see whether they indeed have been infected with either HIV, hepatitis, or syphilis. So we need to explain to the family that this is an effort to stop transmission. That's true for hepatitis B and HIV, but it's not completely foolproof. So that's quite an important part of the counselling, that, you know, we're doing something to reduce the risk, but it won't bring it down to 0. I think that's fair, isn't it, Catherine? Next slide, please. And I think back to Catherine now.
Yeah. So you know, just the last slide really is the reminder of, you know, this the HIV risk assessment part is a very small part of all the other processes that will be going on for this young person, not only with respect to their health needs, but also with respect to any ongoing police investigation, any ongoing social services involvement, obviously the you know, emotional and well-being impact of you know, what's gone on them, but it's important that we try and provide as clear and as sort of unified health follow-up plan as we can, because there's a huge amount to think about. So as well as all the, you know, the HIV follow-up, it's also thinking about all those STI screening, as we've already discussed. It's remembering things like emergency contraception that can be offered at the acute event, follow-up pregnancy tests, hepatitis B vaccinations, as Jennifer has already mentioned. Ongoing support around their well-being, and referral to independent sexual violence advocates. So that tends to happen via the SARC. So if somebody's seen here acutely, then we would make sure that they are referred to either one of our locality independent sexual violence advocates, or referred to a locality if they're from an area outside Cardiff and Vale. And also thinking about that ongoing safeguarding aspect. So, you know, it should be that anybody who's come through the door of SARC has, who's under 18, has already had a multi-agency referral form submitted, so that we can make sure those safeguarding elements with respect to child sexual abuse are also, all those needs are met as well. So that is the end of our slide. So I'm going to stop sharing. And open the floor to questions, really. So I don't know whether people either would like to put things in the chat, or whether people just want to raise a hand. So I've got Carla, if you'd like to ask.
Hi, thank you. That's been a really great presentation. I'm Carla. I'm a consultant in HIV and sexual health up in North Wales, but does provide some support to our paediatric service as well. I was interested on the PEP issue about the not to dispense the full course. So in paediatrics, do you only set like dispense what, a 3-day, a 5-day, or a 30-day pack?
It'll depend what they're on, because depending on the formulation, it'd be handing out the bottles of, you know, the liquids, or it's more just that. Whereas we've got, I know the sort of the trend is to move towards giving the full course for adults. I think it's that issue around making sure that we've got that early review and that further early sort of reassessment of the risks. And I think, you know, there's so much that the young person is information that's been given to that young person and the family following that acute assault. And I think it's that opportunity to have an early targeted discussion around the PEP and the risks and the medication that I think if you just sort of send them off and you know, with a full pack, you may potentially lose. So that's the main reason we've got that there at the moment. But you know, that may change. But in practice, it's often that they've got more than just the 3 days because of what they've been sent away with.
That was really just going to be my feeling, because if particularly the raltegravir 600 milligram formulation of it, the leading reason for having to switch to a 30-day pack for the adults is because of lack of stability data, isn't it? I know you've discussed with Fiona Clark, and I know we've had lots of conversations over, I think it's probably the last 2 years on that. And so that's probably in North Wales where we've moved all of our to 30 days, but not for those younger children where those other formulations play such a vital part. Thank you.
Yeah, so I think, thank you very much for that, Carla. I think the other thing is having stuff available in the SARC. When we first started this, the nightmares around where to go and get the drugs, and trying to avoid sending people to different places. You know, once they get there, they just want to get home, sort of, you know. So I think that it was all a part of that, really. But you know, common sense sort of comes into play. And particularly in the sort of the older ones who are going to be linked into the CRI, you know, we may well end up, you know, giving them more. And you've obviously got to sit there and work out, are we in May where we have a ridiculous number of bank holidays? So, you know, you've got to think about where you are in the timeline. But the most important thing was to you know, bring them back and make a coherent decision and make sure they were being supported.
I've got Sian with a hand up.
Hi. Yeah, great. Sorry, my computer went off, so I'm not sure if this question's been asked. But with the different medications, there are some risks of some side effects, which you've noted. But obviously the preparations, they're so much better now. So when we're counselling on terms of, like, you know, what's the chances that they actually get nausea, diarrhea and headache with the current formulations used, you know, how do we explain that? And if they do vomit to dose up because things, you know, have to be taken at a certain interval, you know, how do we advise them with that?
I think you just sort of manage them a bit like you do with any sort of medication now. We're very experienced with these medications. Kids that we're starting on these drugs are doing really well, and we're not getting a lot of reported side effects. So it's when you start them on, it's like you start the children on anything, really. So whereas before with the Calitra, you'd sort of almost say, you know, you are going to be sick when you take this. You know, it's completely different. Yeah, and I think if they're sick, then, you know, if they're sick within an hour, then, you know, they should repeat it, you know, when they're no longer feeling sick. But I wouldn't, it's important to sort of mention that they might feel sick and things like that, but actually not sort of not totally convince them that they are going to be sick, sort of as we used to do. But yes, if they vomit within an hour, then to repeat it, but only obviously when they're feeling a bit better.
Great, and it's really helpful to know that most of them are crushable now, because some of the tablets used to be quite big and they're quite scary in terms of size, and so know that you can break them in half or crush them.
Well, you do have to be very careful though, and make sure that you are telling them to crush the right ones, which is why that table is so important. So only certain ones are crushable, only certain ones are dispersible, and then the other ones that are chewable. So you do have to be quite careful as to which ones it will say if they can be crushed. And we've sort of, Catherine, Fiona and I sat there and sort of went through lots of possible sort of combinations, and that's why it does look a bit confusing, but it is accurate. It's been cross-checked a few times.
And usually when this new starting is always on a bank holiday weekend. So it's helpful having the St Mary's number there. I guess, you know, obviously we can advise them. We know who to contact for advice, but the patient then goes away for maybe 3 days over the weekend, and you know, you've arranged your follow-up for the Tuesday. But you know, if they have any questions over the weekend, you know, who's best for them to contact?
CAU.
Okay.
Yeah.
So I think if you had a regional case, and if it's a young child, then I'd probably see if I could speak to the on-call consultant and say, we've got this young person who I'm sending back down to Haverfordwest. Is there a point of contact if they have any needs? And obviously let them know the backup number for, you know, the HIV specialists over the weekends. But I think it's so case specific, depending on age, depending on locality. But as you say, if they're Cardiff, then, you know, maybe see if we can arrange open access to CAU is a useful thing. So
yeah, that's helpful.
yeah,
it's a good thought. Okay, great, thank you very much.
any other questions? I can't see any other hands at the minute. So I think, and if we put in the chat the links to the presentation, and then you'll be able to be able to get that clear view of those tables with all the drug doses. So I didn't realise that they wouldn't quite project quite so well. So yes, we can put that into the chat, and maybe we can share that alongside the recording of the video as well. So yeah, so anybody else, any other burning thoughts? No. Oh, well, thanks. My thanks really to Jennifer and to Fiona for helping us put this together, and to agreeing to do this teaching session for us. And you know, if you can let any colleagues know that it's available and where to find it, and you know, and share widely, that'd be great. Thank you.
Thank you all, and thanks everybody for attending today. Diolch yn fawr, and have a nice afternoon. Thanks.
Great, thanks very much.
Thank you.